do an introduction and then we can start.
Great.
Okay, so good afternoon, everybody, and welcome to seminar for today. Today is the last one, and we are extremely excited to have our speaker, who specializes in complex adaptive system modeling, agent-based simulation, performance measuring, and process improvement. She has a research sponsored by several federal and state agencies, including the NSF, the AHRQ, that's the Agency for Health Research and Quality, in the city of Arlington, Texas. She's a member of IIC and also currently the Vice President of the DFW IIC Professional Chapter. Please join me welcome Dr. Yuan Zhou. Hopefully I pronounced the name well.
Yeah, that's great. Good afternoon, everyone. Thank you, Dr. Nauma, for the invitation. I'm very pleased to share my this collaborative research with my colleagues on this COVID-19 planning. So my presentation title is the balancing the protection of COVID-19 at risk population while reopening communities. So this is a very important issue during this COVID pandemic. So let me go ahead and start to introduce my, how can I'm trying. Sorry, for some reason my.
Oh, you're able to move.
Oh, okay.
Oh, yeah,
okay.
That works now.
Yes, I'm doing the other one. Sorry. Yeah. So this is our Cosmos COVID-19 research team. So we have a center on stochastic modeling, optimization, and statistics. So this is our whole team. So we have Dr. Victoria Chen. So she's the director and co-founder of the center. And also she's leading this COVID-19 research. So her and also Dr. Jay Rosenberger's expertise focuses on optimization and data decision analytics. And my area of expertise is mainly focused on the computer simulation model, in particular the agent-based simulation. Actually, I have been working on the pandemic modeling research and policy development for about more than 5 years. So I actually started for my PhD dissertation work, so for which I actually developed a spatially explicit agent-based simulation to investigate how the influenza transmitted in the public indoor environment. And also I studied the effectiveness of how the flu vaccine and public social distancing going to take effect to prevent disease transmission. So we also have, our team also have collaborators, Dr. Liu from Stevens Institute of Technology, Dr. Anna Hadid from University of Illinois, Chicago, and Dr. Zhou from Cornell University. We also have students, 6 PhD students and 2 undergraduate students who has made tremendous contribution to this research. So here's a timeline for our COVID-19 research and also some of the major events that actually taken place in Texas state. So on the right side, so I show those major events. The outbreak of the COVID started in March last year. And then following the following month in April, we had the major lockdown across the nation. And then immediately after April, in the early May, we start to reopening very soon. So the school remain closed, and then the other services are allowed to have the 25% capacity. And then just down the road, so we keep kind of expanding the reopening capacity. So this is the phased strategies that has been implemented. And also in the September, the school has been reopened and also the universities at the same time. And the vaccination has been launched in December last year. So we prioritize the healthcare workers. Those are the frontline workers and also the residents in the nursing home. I actually got my vaccine shot, the 2 doses in March. And starting from March 29th, so we actually, Texas gave the vaccine to everyone. So those are some basic or the major events that in Texas for the COVID interventions. And on the left side is our research team timeline. So this research team has been formed around like April time, just right after the spring break last year. So since the disease got more and more severe, so since we're doing the decision making support, we wanted to see if we can make some contributions to help mitigating the pandemic outcomes. So we formed a team, and then we had some discussions there around the time, and then we finalized our topic to study the trade-offs in between the pandemic outcome and the normalcy for the reopening. So this is kind of the major conflict objective during this planning phase. And then we have a couple deliverables based on the research. So we had a podcast for the informs settling human series. And also based on this research, we have developed a linear programming tool, which has been launched in July. And then following that, we've been keep working on this research, and then we submit to the competition, which is C3 AI. So they provide some data. They have a data lake, and also we combine of some data we found online, like census data, and then we develop this. We submit this too, and then we got the third place for this grant challenge on the COVID research. And then we also got one manuscript submitted based on this. We call it the CC19LP. So that stands for Cosmos COVID-19 Linear Programming 2. So that paper has been submitted last month. And then currently I'm working on the agent-based simulation, which we're trying to integrate it with the LP model for more additional, testing and modeling purpose. And then I have a link here. So let me click on that. So we have posted. So all our deliverables has been posted on this website. If you would like to know more details about our COVID-19 research, this is going to be a good source. Okay, did it actually show up the website? Okay, so I don't think the website is actually pop up. So I have the link already, so you can take a look after, at any time later. Okay. So let me go back to my slide. So here are some some of the kind of agenda items I wanted to discuss today. First, I wanted to address some of the challenges in the COVID-19 planning. And then following that, I'm going to introduce the two kind of we break it down the project into two smaller projects. One is this linear programming tool, and the other one is the agent-based simulation led by Dr. Chen and myself, respectively. And then I'm going to conclude this study by some future work and my takeaways. So I already talked about the kind of the conflicting objectives during this COVID-19 planning phases. So we've seen one is to further reduce the transmission and fatalities after the major lockdown in April last year. And on the other side, since the pandemic has impacted the US economy so badly. So we wanted to reopen the communities and the economy as soon as possible. By doing that, then we are going to increase the normalcy of the activity levels. So there's a conflict objective in there. So this is kind of the motivation for this research. We are hoping to, by creating some, doing some analytics, by creating the models, we can support some decision making for planning the COVID mitigation. At the same time, we're maximizing the reopening normalcies. There are also some other challenges in this planning. One is the impact of the survival rate. Yes.
Hello.
Yes. Okay, so if you have any questions, feel free to ask at any time so we can make this a little bit more interactive. And if you want it, you can also ask by the end of the talk. So there's some other challenges I've been talking about now. So the survival rate for some of the infectious disease like the SARS, so that actually going to impact the individual significantly, meaning that they're gonna develop very severe disease and the survival rate is pretty low. So in these cases, the subsequent results is that the disease is not very, cannot continue to spread in the communities. However, for this particular COVID, it's a complete new virus, and we already learned the survival rate is relatively high compared to some other infectious diseases. So it's actually enabled the infected individuals, in particular those asymptomatic and pre-symptomatic cases, to continue activity in the community, therefore to spread the disease. Kind of what we call it a silent transmission of the virus. So that's kind of a major challenge, another major challenge for the planning, since those stages, the asymptomatic and pre-symptomatic stages of the disease are not observable during the transmission. And also, we have the mask use and social precautions challenges for mitigating the transmissions. So the CDC has been giving policies and guidance how we do the use masks correctly and do the 6 foot social distance. However, those are kind of have a low compliance for the social precautions, and those are not easy to control. That's more based on the human behavior. And also the so mask wearing seems not realistic. So people still having conversations without a mask, but this has been improved a lot from the beginning of the pandemic. So for the planning, the COVID planning relies on the information significantly. In the general context, we're talking about 3 types of information in terms of their uncertainties. So we have the information that is known with certainty. We have information from data with some uncertainty. We also consider those are good data. And the last one, we have information that is highly uncertain. So we have to be really careful when we use those highly uncertain information. Okay. So in the next couple slides, I will show some examples for each type of the information in the context of COVID-19. For the reliable planning, the best strategies, so I highlighted a couple here. So it includes leveraging the known information and the reliable information. So that's kind of to ensure the validity and also the reliability of the known information. And for the highly uncertain information, it is important to study various possible realizations or scenarios of those information, including the worst case scenarios. And the last one, we need to be more focused on the achieving clear objectives. So those are some good practices when we do the planning in a more reliable way. So for the information that with uncertainty, I've listed those items here on the slides. So we know the hospital capacity, we know that is limited. So based on the report, the EHR data, the electronic healthcare data from the hospital or the clinics, we can actually collect those information in a pretty with pretty good certainty. Also the high grade or the medical grade personal protective equipment, the PPE, also very limited. Okay, so we had a pretty bad, significant shortage for those PPE at the beginning of the pandemic. And also the lockdown negatively impacted US economy. So that's actually a fact. So evidence has been showing that a lot of people has lost their jobs and very hard to make their living. And then the higher person-to-person interactions will increase the infection risk. So the COVID-19, similar to other infectious disease like influenza, SARS, Ebola. So those kind of diseases are actually transmitted based on the person-to-person interactions. So that the more interactions will actually increase the transmissions. The last one listed here may not be list. So that's the personal hygiene will help reduce transmission from services. Okay, so those are a couple examples to show the information that with uncertainty. And then we have some good information from the data. So the first one, we have certain conditions that have a higher risk for severe illness. So based on the CDC report. So we know such as the heart diseases, obesity, diabetics. So those are a couple examples that are the medical condition which result in more severe illness. However, it is still uncertain which one or which are the ones are predominant. Even the two those individuals who has the same condition may result in different severity of the disease because it's so complicated of the health or the human body with the health conditions. So those are with some certainty, but so those are some good data we can use when we create the model. And then infected individuals that are symptomatic or pre-symptomatic are contagious and can spread the virus. So based on the empirical studies, so those evidence has been showing this fact. But those stages, as I mentioned earlier, are not observable. So still creating some of the challenges for using this data. And then the social distance reduces person-to-person transmissions, although the safe distance is uncertain. So we're using the 6 foot distance as the threshold. So actually for the influenza, the 6 feet distance is actually originally used for controlling the influenza pandemic or epidemic. So this is a distance we can of uncertain, but this is a kind of a guideline showing that it can help reduce transmission. Also, the face covering has been suggested to use together with the social distance to improve more protections from the transmission. And the couple more here, just go through that quickly. So face covering are effective in reducing the transmission. However, since we have different materials has been used to produce the masks, we have the N95, we have the surgical, we have the cloth mask, we have the face shield, so many different type of materials. So the efficacies still remain uncertain, compounded with how people actually use the mask, which also may result in different consequences. Also, the ventilation system may help. So the poor ventilation system in the indoor environments may increase the transmission risk. So the last one is talking about the false positive rate for the testing is actually, we have a low false positive rate, meaning if you don't have the disease, you actually have a very low chance to have a positive test results. And then we're going to show you for the other results, which is actually the uncertain data and unreliable information, which is the false negative rate on the testing, which is actually very high. Meaning that if you have a result, if you have a disease, but actually it's up to 30%, you may not be able to, the result may not show up that positive results. So a negative results from the COVID test cannot be confirmed whether this individual is actually affected or not. So we've probably heard some previous cases that saying that individuals may test 3 times. This person has been found actually positive, but the previous 2 results actually turned back negative. So we've been having some cases to show the consequences of this high false negative rate on the testing. So the US for the contact tracing, so that contact tracing has been implemented in controlling the spread. So by this, we can kind of detect people's upfront, with the symptomatic cases to know who might be infected. so we can take we can take actions, on those individuals. For example, make quarantine or isolate those individuals. So hopefully by doing that, we can, slow down the transmissions. However, the contact tracing is very hard to control. And also this actually also depending on the magnitude or the timing, how you're going to do it. Basically, its effectiveness is still unknown to some extent. Okay, especially for the for this particular COVID-19 research, COVID-19 disease, we mentioned the asymptomatic and pre-symptomatic actually take a large portion of those cases. So actually, those unobservable event is make the contact tracing even harder. U.S. compliance with CDC precautions is unacceptably low. So that's actually implied by the case number. We actually don't have such data has been collected so far. So that's data is, it's not available at this point. So the temperature checks can only catch those with symptoms. So there's example for the for a wedding reception in Maine in August last year. Is actually they do the temperature check. However, they still got a very severe consequences based on this event. So we're gonna have a check mark in the next slides for this event. And then the last one, reduction in person-to-person transmissions due to high air changes per hour beyond reasonable standards has not been demonstrated. So again, that's for the like the ventilation system, how it's going to affect the transmission is still uncertain. Okay. So actually, I wanted to talk about this event a little bit on this wedding event last year. So this actually, in August, the people have already have a very good awareness of the pandemic. So they actually take actions to control or to check all the, the guests to enter the event. So they did the temperature check. They also do the symptoms and they check the results if anyone got negative results, positive results on the COVID. However, there are 55 persons attended this event. The results got they got 177 COVID cases based on this one single event, and then there are seven were hospitalized, and also there are 7 people dead from this infection. So they did investigations. Actually, they reviewed the non-compliance with the CDC recommended mitigation measures has been found. Okay, so those are just one single event actually linked to many cases. So it could be a very severe, kind of examples we wanted to, take some lessons from. So those are mainly rely on those uncertain information. As we mentioned, we wanted to be very careful when we use those uncertain informations to control the disease. Again, for the strategies we mentioned, we wanted to focus on those reliable information. Those information includes higher risk conditions that has been identified by the CDC, and also must conduct control strategies in addition to the contact tracing. Again, contact tracing is not by itself, it may not reliable. So we would like to combine with some other control strategies. And then the needs for the community cannot be ignored. So we have people will risk themselves to meet their financial, social, or economic needs. So that cannot be ignored when we do the decisions making analysis. So for this particular research, we have this clear objectives we wanted to achieve. So basically we're talking about 2. One is to minimize the severe cases by implementing or by effectively use those resources, including the PPE, the testing kits, also the vaccines. So we wanted to also come up with a strategy to prioritize the vaccination groups. And then at the same time, we wanted to ensure we're enabling the reopening of the community and schools at a desirable levels. So our model assumptions are listed here, including people needs to work and participate in activities. That's how we're going to ensure, the normalcy or the reopening of the communities. There are also unknown cases for each known cases, though those captures the asymptomatic and the pre-symptomatic cases in the community. Not all high-risk individuals can shelter at home. Okay, some high-risk individuals still have to make their living, meaning that they have to go for work. So those people, those high-risk individuals cannot avoid interactions with other, individuals who might be infected. And the last one here is the only strategy that prevents transmission is sheltering at alone. So those are kind of make it a little bit more restricted. So we only consider those people that can be sheltered. Those individuals can be well protected from the transmission. Okay, so those are our model assumptions. And again, our goal with those objectives is to balance the protection or maximize the protection of the high-risk individuals. And then we wanted to reopen the community as a high normalcy level as we can. So based on that, we've been having some discussion how we come up with a framework or a way that we can separate the high-risk individuals from the other groups so we can protect them, okay, effectively. So this is the key contact partitioning framework that we developed in order to address this particular issue. So in this diagram, we have three. In the middle is the key contact individuals. Okay, so those are those groups include both high risk and low risk individuals. And then the first group in blue, we call it sheltered high risk individuals. So those individuals we consider as the one that can be isolated or sheltered at home. So they can get assistance from the key contact individuals from this red group. So you see the connection, those people, those individuals in this blue sheltered group can only make connections or interactions with the individuals in this contact group. They cannot have interactions with this green group, what we call a baseline low risk individual group. Okay, so that's kind of, distinguish these two by, giving certain interventions. They cannot be interacted with each other. And then we have the green group, which this the baseline group. Those individuals are all low risk individual by the definition of the CDC. So we're talking about the high risk individuals who are 65 years old and older. And then we also have the individuals at any age who has at least one underlying medical conditions like heart disease, obesity, and liver diseases. So those are the high-risk individuals. Okay, so we have this group. So we will try to have them to have as much as normal activity, as many as normal activities as they can. Based on our interventions. And then this middle group, again, are the high risk or the key contact individuals. So that includes the high risk individuals who cannot avoid going to work and make connections with the low risk individuals in this baseline group. Or they can be the low risk individuals. They can go to work, and also they are going to help with the sheltered individuals for their daily activities. So they are the one actually assisting these sheltered individuals to protect them. Okay, so that's the key contact partitioning structure, kind of the fundamental framework for this modeling research. So just an example for this, how we identify a household that includes 2 low-risk kids and 2 low-risk adults, those are the parents, and then 1 high-risk grandparents who are not working, who not employed. Okay, so in this household, based on the key contact structure definition, we have the low risk. The two kids are in this low risk baseline group, and then we also have one of the low risk adults also in this baseline group, and then we have another low risk adult as the one actually helping with the grandparents who is in the sheltered high risk group. So this is one example showing, so based on the data we have, then we are going to, identify the role for each individuals and trying to figure out the fractions or the individual in each group. So here's a questionnaire we created. Let me see if I can bring that up. Okay. So this is the questionnaire online we developed to identifying for identifying the key contact individuals. So we give a little instructions for the definition of each group. And then if we hit next, they will ask you, does your household have members aged 65 years and or older? So if you have yes, you can click yes. If no, then you can click no. And then the same. Okay, next. And then we're gonna select one of the following options, whether we're gonna continue with the household member age 65 years older, or we can continue for the members that are younger age. So this is just ensure that we wanted to have the older individuals to fill out this form first, then we can base on the information to identify the role for other family members. Let's see, I'm the 65 years and older individuals, and then they will ask, do you have at least one medical condition? So we give a link to the CDC, and then we click yes. Then do you need to work? Then I click no. I'm retired. And then can you isolate yourself sheltering at home by having help with the caregiver? So yes. And then based on that information, then they will show you the role for your, based on this key contact structure. Okay, and then you can try based on your role, and then ideally we're hoping to use this questionnaire to get a good sample of data to understand in the community the fractions of the population in each group. Okay, so let me go back to the slides. So based for the data to identify the those key contact groups, we're using two major sources of data. So one is the 2018 census data. By having this data, we can get the fractions of population by the age group, and also the persons living in the quarters, household, the fractions of or the number of persons in the labor force and in the college, and also some household information as well as their occupation information. So the last bullet here is the person living in poverty. So we use this information as a surrogate for the crowding information. As for the crowding information, this actually, we come up with this idea with a conversation that Dr. Chen had with a experts in the infectious disease. So the crowding is actually meaning that the individual living in the information that cannot avoid or cannot comply with the social precautions by having the 6 feet distance. So those are the crowding information may increase the risk of transmissions. So that's one of the factors we're considering in the model. And then the other data source is this CDC 2018. It's a behavioral surveillance data survey. So we use that to identify the medical conditions of the individuals in the population. So our model is created based on the county level. So we're analyzing this based on the counties. So this is an example showing the Tarrant County. This is the county where I'm living. So this is the key contact partitioning breakdowns. So we have 4 labeling here, the 4 label here. So the H1 is the high risk adult individual adults living in a non-crowding environment. So you see that's take a large proportion. And then we also have the high risk individuals. Those are all the key contacts. Okay, so high risk key adults living in a crowding situation, 11.5%. And also we have a small portion of the low risk key contact individuals, L1. So those are the K to 12 school age children. And then we have about 10% of the low risk adults in these key contact groups. So in total, they made up about 35% of the total population in Tarrant County. And here just this number. So those are the breakdowns based on this percentage. And then we also studied, listed some the key context proportions, the percentage in other counties. So Dallas, Miami-Dade, and Queens in different states. So we can actually see the percentage of the key contacts are very are kind of consistent across different counties. And also the table on the bottom listed the breakdowns for those 4 categories of the key contact type. So our objectives, again, for this linear programming, so we try to minimize the expected fatalities. So in this particular model, we are focused on the fatality rate of those sheltered high-risk individuals who are in the group 1, the blue group, and also the key contact individuals in group 2, that's the red group. So this is our primary objective. And then since we mentioned we are trying to do the balance, we actually have 2 objectives here. The other objective is to remain a desired or acceptable normalcy level. So this we actually as a constrained objective, meaning that we consider this in the constraint. Okay, and then the decision variables on the key contacts mainly focus on how we're going to assign the key contact individuals to the occupation and the specific activity level. And then those through 2 to 4, those are the ones going to be assigned on a particular intervention, including the PPE, the PCR, that's the COVID testing, and then we have the vaccine. Okay, and then the constraints. So we have a number of constraints. So here's important constraints, including the PPE, testing, and vaccine resources based on their capacity, and the crowding activity levels may include the maximum fractions of the key contacts whose active level can satisfy, 0 normalcy, meaning they can be completely quarantined or sheltered. And then we also consider the limits on the occupation types. For example, the maximum fraction of the key contacts that can do the work completely online. So for those people living in a crowded environment, so that may not be the case. So those are the objectives, decision variables, and some important constraints considered in this LP model. So let me just go through quickly for some of the occupation for the parameters we use. So those are how we assign the key contacts into different occupation. Occupation, we consider both school and work at different level of the social precautions, with social distancing, without social distancing, or completely online. And let me go through this quickly. And then the community levels, we consider 5 levels, just roughly categorize them into the scale from 0 to 10 actually. So we use the percentage to represent here, 0% meaning 0, and then 12% activities, meaning that they can do about 20% activities in the community, maybe go to the restaurants with the the wearing the masks, and then the 50%, 70%, 100%, meaning that we're going back to the pre-pandemic and normalcy level. And then these kids will be assigned to exactly one occupation type, that's the school type, and also one community activity level. And then for the adults, they will have a category for the work, their occupation, and also the community activity. So the decision variables is, as we mentioned, based on the assignment of the key contact individuals for each occupation group J with the activity level K. Okay, and then index is based on the 4 categories of the key contact types. Okay, so those are the, so with the index M, T, and V, that's represent the assignment on different interventions. So this one showing some of the occupational and activity weights we assign to. So the main goal is that we wanted to have the low risk to be the key must provide assistance to the high risk sheltered that cannot avoid contact. Therefore, they cannot be the online. So so this is actually including the, we are assigning a higher weight to the one actually we allow them to have more normal activities compared to the 0, which is more restricted level of the activities. In addition to those, we have some probability and fractions has been assigned on the testing and quarantine compliance, and also the transmission probability of based on a contact, which is contagious contact. So those information were using the data we pull from the literature to assign those probabilities. So for example, the transmission probability for the high risk transmission is 0.05 because the transmission upon contact is still going to be a stochastic event. So that's we use this transmission probability to capture that. Additionally, we also consider the daily contact rates based for the for those key contact individuals in different occupation, different community activity level, and also the one actually have interaction where needs to assist the sheltered high-risk individuals. And then the rate of infections has been included here. So those are the rate of infections for the key contact in occupation J. So those are, so this row for the J and K, those are the total contacts made by these key contact individuals and multiplied by the P plus. So this is how many contacts are contagious. Only the contagious contacts will be effective for, transmit the disease. And then this first term is the probability to transmit the disease. So for the product, it gives us the rate of infections for the high-risk key in the occupation J with activity K. And similar for the rest. Sorry for going through this a little quick. So I wanted to get to the results. So we also consider some protection factors based on the, those interventions, wearing the mask with the vaccination, and also considering since this disease has a minor impact on the school age children, so we give a reduction, a scalar for those children. And then the formulation of the linear model is based on this sequence. So that's the overall sequence. So first we add the key contact fatalities without the transmission interventions. And then we also add the one for the sheltered high-risk fatalities associated with the infected contacts. So those 1 and 2, we add together to get total transmission, total infections. And then we're going to subtract the numbers that can be saved by having the interventions of the PPE and those and vaccines. So those are, or the quarantine, the following by the testing. So, and then we subtract the sum of 3 to 5, then we get the expected fatality rate for for this county. So quickly showing. So this is our one of the without the interventions, the expected facilities with the high risk and the low risk in different occupation and activity J. And then we also consider the, as we mentioned, the desirable level of normalcy has been put into the constraints. So this is the constraints for make sure the lower limit on the normalcy to ensure we can have that as the desirable or the minimum bound for the desirable activity. So let me just show you quickly the results. So this is the Tarrant County results, and then we use, this is the category 1 and 2 minus the sum of this total because we don't have any interventions. So this is the total fatality rate. So per day, 2.68 during this period. Okay. And this is the kind of showing the interventions by different categories of those decision variables. Okay. So this is kind of reasonable or consistent with our intuition or common sense. So the PPE, so those one actually on the right compare with the one without intervention has been allocated to those individual high-risk key count individuals living in the crowding situation. We also have a small portion of the testing that has been given to the low-risk individuals who work without precautions. Okay. I think I'm running out of time. Do I have more minutes? So I'm gonna finish up.
You have 9 minutes.
Okay, that's good enough. So we also did some benchmarking runs for different counties. So the previous example shows Tarrant County. We also did some other runs to for Dallas, Miami-Dade, Queens, and some additional ones. So this actually also trying to test with the, so this is the actual fatality rate during this period. So for example, the Tarrant from May 1st to May 31st. And then we're looking based on the ratio. So this ratio is the unknown to known ratio. So we found this is the closest one. So the 4-to-1 ratio provide us the closest fatality rate to the actual fatality rate. And also the minimum normalcy level is around 2.7 because we still wanted to have, have healthcare workers or some other, essential workers to work at the same time. So that's allow us to, ensure that is guaranteed. So this is for the spring summer testing around the April, May, and June time. And then we also did similar study for the fall period. So that's from September, October, around that period. And we're also giving the PPE test during the period because the more availability of the supplies, during that time frame. So this is, again, we're looking for the closest fatality from the LP model that is close to the actual model based on the 4-to-1 ratio. Okay. So those are the benchmarking runs for that. And then the next part is the projects we conducted based on the computer simulation model, which we're trying to use that to mimic the transmission dynamics and also use that to evaluate the effectiveness of the disease policies and interventions. In particular, in this research, we're using that to validate our the LP results. So just a very brief a view of the agent-based model. So compared to some other simulation approach that you may be familiar with, like the discrete event simulation or the system dynamics. So the agent-based model is approach is a bottom-up computer simulation approach. So it focuses on creating the focus on the individuals, or we call the agents, based on their attributes and behaviors. And the other important things is that we are looking for the interactions, how the individuals interact with each other. In particular, that is important for this disease modeling. The contact is kind of the key that drives the transmission mechanism. And then based on that, we will have the transmission. So the last one, we're also looking for the environment that may change the behavior of the agents. Like if you implement a new policy or you're giving the intervention, so the agents may change their behavior in the real time. So how it works. So we create a synthetic population first to realistically represent the static population in the context of the study. So which in this one, we're using the Tarrant County as an example. And then we generate each individual person as an agent, as a person agent, and then we categorize them with different attributes. So those are some attributes we created, like their age, gender, medical condition. Again, those data we're pulling from the census. And then we also have household. Each household is also represented by a computer agent. So by having the household, we can make the connections with the individuals and the household using this household ID. Okay, so and then we can study the structure of the household and then be able to assign the key context structure into the household or the population, which we validate with our LP model results based on the key contact breakdowns. And then we can continue to model the transmissions based on this synthetic population. And then to model the behavior of agents, we consider the contact and the transmissions. So the contact, we are using the contact rate. So those are the number of contacts per individuals per day, which is also by age group and also by location specific. And then we have the transmission, that's the probability we use to from person to person. We also consider the what we call SEIR transmission framework that models within the household, within the host, or within the person, how the disease is progressed. Okay, and also we consider the changes of the behavior based on the environmental factors. So this is the SER framework that has been used significantly in the epidemiological research. So this has been modified based on the original one. So we consider the SEIR, which stands for susceptible, exposed, infectious, and recovered. And then we also add asymptomatic, pre-symptomatic, and symptomatic stages into this along with the healthcare treatment in order to represent a more realistic situation. So the latent period, meaning that you are infected but not yet infectious, so that may take 1 to 2 weeks, 1 day to 2 weeks. And the incubation period is the time when you develop your symptom, though that can range from 2 days to 2 weeks. And then the infectious period, meaning that the period you are infected, you can transmit disease to other people. So that's actually have a large variety based on the literature. So in this model, we use 1 to 10 days as the minimum and maximum. So the contact rate, as we mentioned, we divided into, we stratified that by the age group and also by the location. So here's the data we pull from the existing literature. And for the transmission probability, we utilize this to incorporate all the interventions like the social distance, the PPE use, and also the vaccination into the calculation of the transmission. So a survival function has been used in this case, and then we use a figure to show the patterns of the changes in transmissions in different age group. So here's how we implemented in the simulation toolkit AnyLogic. So it's a Java-based multi-simulation platform. So you can see here we generate the attributes using those parameters and variables. And also the on the right, we have the state charts, which were used to govern the behavior, the SEIR behavior of the individuals, and also with some healthcare behavior with the testing situation. And then in the middle column is actually how we integrate this agent-based model with the LP model based on their decision variables. So we have the fraction or the assignment of key contact individuals into different occupation as well as their community activity. So this can help us to make the connection so we can study how we use the agent base to validate the LP results. So we're still working on that. So this is a preliminary results we use to study the kind of the periods from April to May period. In our table. So by implementing the testing interventions over this period from April 10th to 30th, the fatality rate developed from this agent-based model over the next period because they have some delay in fact. So it's 2.73 per day. And then we have the confidence interval calculated. So this average number is pretty consistent with the LP results, which is 2.67 per day for the fatality. So this is the kind of the preliminary results we get for the agent-based model to how we use that to validate LP. To conclude the study, so we use this LP, CC19LP model to demonstrate the effectiveness of an aggregated approach to matching the reality and identifying interventions that simultaneously save the most lives while reopening the community. So again, we're trying to balance in the pandemic outcome and the reopening normalcy level. And then the ICAR agent-based model provides a more realistic representation of how the disease is transmitted in the population. And then the integration of those two prepare a platform for developing a more computational fast optimization in a more realistic manner. And then the key contact questionnaire we developed, and then with the CCLP online tool can support decision makers in the COVID-19 planning, in particular how they assign those resources to the particular key contact information to better protect the high risk individuals, and including the vulnerable and older population. So the future work, so as we still do the benchmarking runs for the LP, and also we're going to focus on more on the integration of the agent-based and the LP model for validation and more advanced planning, because agent-based model give you more granular information for the decision making. So by that, we can have more tactical, not just the strategical, but also tactical actions to be taken for mitigating the disease while reopening communities. And also we wanted to focus on the long term of the COVID-19 planning, as we kind of by having maybe from the news or the some of the literature. So they were saying the COVID-19 perhaps to be, kind of coexist with other viruses, or it could be a long-term thing, just like a flu, influenza, or a seasonal flu. So we may consider in that situation how we do the planning in a proactive way. And then we also see there's a critical needs for the IEOR research in the COVID-19 planning. We've seen tons of models that has been created to study the transmission dynamics of the COVID-19, including the agent-based model, system dynamic simulation model, some mathematical model based on the differential equations, and some other tools. So tons of study has been done that. However, we see a few studies has been focusing on using that to address the decision-making needs for this COVID-19 planning. So I think from the industrial engineering perspective, we can do more and do better for making good contributions in this area. And some takeaway, so for this research, so we got some misleading information at the beginning or early stage, like we only encourage people who got the disease wearing the mask, which actually did not protect individual, whether you are infected or you are the healthy individuals, is actually not helping or control the disease from that perspective with the best protection. And then we're actually too slow to recommend the universal mask wearing. So we had that in Tarrant or in Texas in July, which was already a couple months after the outbreak. Actually, the early stage of the pandemic is the most critical time, okay, for control the virus. Okay, so we are actually too late for that. And the lack of emphasis on the effective use of limited resources. So how we allocate the testing resources. So testing resources based on the CDC policy has been given to the one that have already developed symptoms, right? So, and then by the time they are very limited. So for those one, we should be tested and have the high risks, those people were have not get the opportunity to be tested. So that's kind of another emphasis to effectively use the resources, and no early interventions tailored to improve the protections of the at-risk population. So the fatalities are actually those populations are disproportionately affected by the COVID. So we wanted to emphasize more on how we tailor interventions to target those, in a population to provide best protections to reduce the fatalities. Is has not been addressed appropriately. And the last one is contact tracing showed effectiveness. However, it is still a reactive approach, meaning that you know the symptomatic cases and then you're following them, trying to find other cases. From our perspective, view is still reactive. So more proactive approach will be needed to address the to achieving better outcomes. So those are just some takeaways and lessons we learned from this, how we controlled COVID-19 during this time frame. So we're not done yet. So there's still a way to go, but hopefully by having the mass vaccination across states, the disease can be controlled effectively. So by the end, I wanted to give special thanks to Dr. Edelman and Dr. Guild, so who are doctors gave us tremendous, very useful suggestions and advice on this research. So that's the end of my talk. Sorry about going a little fast. I realized the time. So thank you all, and I'm ready for any questions.
Okay. Thank you very much, Dr. Zhou. As you stated, that the time is fast spent. I don't know whether folks have questions. Let's give ourselves about 4 minutes of questions, see if there are any questions.
Sure. Yeah. And also, I have my email address here. So you'll, feel free to send me a message if you have any questions. So I should be able to address. So just quickly, that link I tried to show early is this Cosmos COVID-19 research webpage. So we have posted, uploaded all the kind of deliverables on this website, including the questionnaire, the podcast, and some advices we provided. The school and business, I'm not sure they listen, but we try to talk to the city, Arlington, and then trying to, present this research to them. And hopefully, actually Texas is doing really good on the vaccination, the phased, strategies. So yeah, so that's, for those outcomes.
Great. Thank you.
Yeah.
Thank you so much for this insightful presentation. So are there any questions? You can either unmute yourself and ask a question, or you can type it and I'll read it out, whichever way works for you. Okay, I don't see any questions coming in, but
Okay.
as always, we have recorded this session, and so you can always watch it again. And if you have questions, you can send an email to Dr. Zhou. Her email is in the presentation slides. And that is it. We are so grateful for having taken time to do this presentation, Dr. Zhou.
Yes, my pleasure. Thank you for inviting me. Yeah, I could wish to have more time. Yeah.
Yeah, I'm even talking about the value of your research in the time of the pandemic. It is so vulnerable, right? And so
yes.
Yeah.
So your school.
It is a very. I was going to say it's a very timely topic, and sorry we couldn't bring you here, although you're only about 4 hours away. We couldn't bring you here because of the pandemic, but maybe your models become so useful that the pandemic is gone, and then perhaps you can visit us.
Definitely.
Another seminar.
I would love to. And also I would love to invite you to UTA to give us a talk on your research. That would be great too, once the pandemic is over. Okay. I think we're on the track. So, we see some fluctuations. We have seen some minor surges, from day to day, but in general, the overall trend is getting better. So hopefully we can, get this over as soon as possible. I don't know if your school, are you going back to the in-person modality in fall?
We've always been in person. So last fall we had in person and then synchronous and asynchronous. So we're offering courses in all three formats. And this time we are more in person than, I don't know that, I think there are still some courses that are only offered in in-person formats. But then next semester, it'll be almost all of our courses will be in person, unless, of course, things change, which, like you said, is probably unlikely, but we never know.
Yeah, there's a lot of uncertainty. That's why we also see the IEOR research can help address those by doing, research to deal with uncertainties. That's what we do, right?
Yep.
Make decisions under uncertainty. Great meeting you.
Thank you again. Appreciate your seminar.
Thank you. Yeah.
Thank you.
Great.
Thank you all, and have a very good rest of your day. Okay. Bye-bye.
Bye-bye.